I am Juan Plana. I am the chief of the cardiovascular service line at the Texas Heart Institute at Baylor St. Luke's Medical Center in Houston, Texas. And today we're going to be talking about an interesting topic. Are we intervening in aortic and in mitral valve disease too late? You have over here the central illustration of this a publication by Porter et al. In JACC Imaging, talking about the role of a new imaging modality, global longitudinal strain. Global longitudinal strain is a technique that allows us to really measure the deformation of the ventricle and will take the assessment of ventricular function to the next level beyond ejection fraction. I'm going to use a case to show you how we use it on clinical grounds, and we're going to review the application of this technology in aortic and in mitral valve regurgitation. So before I do that, and since this is a talk given to interventional cardiologists, I want to make you familiar with the normal volumes. Global longitudinal strain is negative. The more negative, the better. What we consider normal is more negative than minus 18. We consider borderline between minus 16 and 18, and we consider abnormal and less than 16. But I'm going to share with you what are the thresholds that work for assessment of aortic and mitral valve disease. So this is the first case. This is a 40-year-old with severe aortic regurgitation. The patient is asymptomatic. You have over here the images. You see this very eccentric jet. And when you take a look at the function, you realize that the function is depressed. You have over here the image in your apical 5-chamber view. And I will show you later the assessment of global longitudinal strain, but you can see that the value is reduced. Now, what do the guidelines tell us in terms of the intervention in patients with aortic valve disease? It tells us that if you are symptomatic, you gotta go for an aortic valve replacement. And if you're asymptomatic, you gotta look for two things. Number one, a reduction in your ejection fraction below 55% or a dilation of your ventricle over 50 millimeters at end systole. Now, let's take a look at this case. In this particular case, this patient already has an ejection fraction, but we're going to take a look what happens with global longitudinal strain. This is the way in which the study was read: severe aortic regurgitation. There is lack of central coaptation with a central triangular regurgitant orifice and mild cause path thickening, and evidence of a hollow diastolic flow reversal of the descending aorta, really nailing the diagnosis of severe aortic regurgitation. You take a look over here at the global longitudinal strain, and in this case, you have the bullseye. It's supposed to be all red, and it's supposed to be all more negative than minus 18. And you see some areas where the global longitudinal strain is very abnormal, minus 2, minus 3, minus 8 at certain segments. So you realize that despite the fact that this is a young patient, this is a ventricle that is suffering. And the global longitudinal strain really tells us that the ventricle is suffering beyond what we will estimate with the ejection fraction that is only mildly reduced at 50%. Again, still meeting a surgical criterion for aortic valve regurgitation. So this is the way in which we read the global longitudinal strain, minus 9.9, very abnormal. Now, let's take a look at what we know in terms of the data from global longitudinal strain. This is a nice study where they follow 33 patients, and they were able to take a look at the characteristics of the patients that remain stable, the 25 versus the ones that had progression. And as you can see, I cannot identify them, I cannot separate them on the basis of ejection fraction, on the basis of end diastolic volume, or on the basis of end systolic volume. You see the p-values, they are all not statistically significant. Nevertheless, what allows us to separate these patients was the global longitudinal strain. You see that the ones that were stable, the mean value was minus 19 versus the ones that had progression they had a strain value of minus 16.3 with a p-value that was statistically significant. Now, the part that is interesting is that aortic regurgitation has been sold to us as a forgiving lesion, one that if I intervene, then the ventricle is going to perk up, the ejection fraction is going to go up, and the end diastolic and the end systolic volume are going to go down. Nevertheless, if you take a look at the bottom to the left, the graph of what happens with a strain, once the strain becomes abnormal, it stays abnormal, which kind of puts our understanding of valvular heart disease upside down. Now, this is data from my former colleagues at Cleveland Clinic, and this tells us that once you develop an abnormal global longitudinal strain, and in the setting of aortic insufficiency, it's pretty high. If it becomes less negative than minus 19.5, this will carry a poor prognosis in terms of freedom from death. So not only these ventricles are not recovering, but there is a price to pay in terms of mortality for these patients. Now, let's take a look at mitral regurgitation, and kind of the same concept applies. You see over here the freedom from cardiac event to the left using a cutoff of minus 18.1, and then to the right, freedom from all-cause death rate, again using a cutoff of minus 18.1. So what is that I have shown you in this presentation? In this presentation, I have reviewed with you a new parameter of imaging called global longitudinal strain. It's a parameter of deformation. I have shown to you the value beyond what ejection fraction brings to the table. And answering the question, I think that we are intervening from taking a look at this data at these patients late. And I really think that in the years to come, global longitudinal strain will become part of the guidelines as a way to really separate the patients that will benefit from early intervention, aortic and mitral regurgitation. So with that, I thank you so much for your attention. This time it had to be via Zoom, and I look forward to the opportunity of sharing this data with you in person. Thank you very much.